college students. And so in the next slide, um, so there are ethnic differences as well. They found that African American and Asian Americans reported more contamination obsessions and compulsions than did European Americans. And this may be attributed to different cultural attitudes towards grooming and housekeeping. Asian Americans had more frequent obsessive beliefs, which may be relevated or may be related to the elevated levels of perfectionism that can be found in the Asian American culture and can also be with comorbid anxiety. And then feeling the need and importance of controlling thoughts was a stronger predictor of unacceptable thoughts or unacceptable thought obsession symptoms for Latin Americans or Latino Americans than for European Americans. And this may be related to higher rates of Catholicism in this population and how that contributes to their value systems. And they also found that group membership can help moderate the effects of contamination and unacceptable thought dimensions of OCD. And in addition, there's also the finding that religious beliefs can affect the content of the obsessions and the compulsions. So, in a study of how religious beliefs interact with OCD, they found that religion can influence obsessions and compulsions to include blasphemous thoughts related to religious themes, compulsive prayer, hypermortality, touching and repeating rituals, repetitive reassurance seeking, and cleaning washing rituals. And this can also be related to making the need to make right sinful actions or thoughts. Um, they found that clinical impressions suggest that holding the belief that one is responsible for sinful thoughts can lead to efforts to suppress or control one's thinking. Thought suppression, although likely effective in redirecting thinking for many individuals, increases the frequency and intensity of obsessional thinking for persons with OCD. So it actually makes their outcomes worse. Additionally, thoughts that are considered to be especially alien to one's true beliefs are particularly likely to intensify obsessions among persons with OCD.
So there is a correlation between OCD and suicidality. According to the DSM-5-TR, the lifetime average suicide rate of is 14.2%. The mean rate of lifetime suicidal ideation is 44.1%. And then the current suicidal ideation rate is 25.9%. And these are all among individuals that have a diagnosis of obsessive compulsive disorder. The more severe that the OCD symptoms are, the greater risk that the individual is of suicide. And then a comorbidity of anxiety, depression, and PTSD, as well as individuals who have already had a history of suicidality or suicide risk or suicide ideation are more significant risk of suicide than those who have not. And then sexuality and religious dimensions of OCD, as well as like the comorbid substance use disorders, were also associated with suicidal thoughts and suicidal plans. And differential diagnosis. So the first ones we're talking about will be anxiety disorders and major depressive disorder. So OCD involves irrational fears or obsessions that are different than real life worries, which those are the ones that are found in generalized anxiety disorder. So it's mainly the fear like, that are irrational rather than everyday fear of, maybe sleeping in late for a test. It's more irrational than that. And then for major depressive disorder, they're ruminative thoughts that are mood congruent with depression and not linked to the compulsive behaviors, unlike those behaviors in OCD. So for the other obsessive compulsive disorders, there is hoarding disorder, which is the difficulty of discarding possessions without the compulsive and obsessive behaviors. A lot of times you'll see people talk about, people who just have a hard time hoarding. They're very OCD. Well, no, that's not actually the case. It's mostly just the difficulty of them discarding the possessions. They're not actually having a compulsive or even an obsession. It's just the difficulty of discarding that. And then the body dysmorphic disorder, those involve obsessions and compulsions, but they're only related to physical appearance. And then trichotillomania. This is always a hard one for me. So this is the compulsive hair pulling. This is some things that people do without necessarily the presence of obsessions. It's just a compulsion that they have. They feel like that they have to pull their hair, especially using, typical social situations. And then eating disorders. So OCD can be distinguished from anorexia nervosa, and that OCD, the obsessions and compulsions are not limited to concerns about weight and food. So kind of similar to the body dysmorphic disorder as well. So the obsessions and compulsions are only related to the concerns about food and weight rather than general obsessions and compulsions that are in OCD.
So for tics and stereotyped movements, so a tic is defined as like sudden, rapid, recurrent, and non-rhythmic motor movement or vocalization. Examples are like eye blinking, throat clearing. Stereotyped movement is a repetitive, seemingly driven, non-functional motor movement, which could be like head banging, body rocking, or self-biting. Tics and stereotype movements are typically less complex than compulsions and are not aimed at neutralizing obsessions. Distinguishing between complex tics and compulsions can be quite difficult, though. Um, so, whereas compulsions are usually preceded by obsessions, tics are often preceded by premonitory sensory urges. Some individuals have symptoms of both OCD and tic disorder, in which both diagnoses may be warranted. For psychotic disorders, so OCD can be distinguished from delusional disorder by the presence of obsessions and compulsions. A lot of the times, poor or absent insight and or delusional OCD beliefs may look like psychotic symptoms. But when diagnosing this, you have to be careful to not categorize these symptoms or give a diagnosis um, of schizophrenia. So in OCD, other psychotic features such as hallucinations and disorganized speech will not be present. So those are the main ways that you can distinguish between those.
And then other compulsive like behaviors could be gambling, sexual behaviors like paraphilias, and substance use. And these differ from OCD because these compulsions usually bring about some type of pleasure or gratification, and they may feel the need to abstain from them to avoid consequences, whereas the compulsions and obsessions in OCD usually cause a lot of distress, and they try to eliminate them for different reasons to like reduce the distress rather than to avoid consequences. And then obsessive compulsive personality disorder shares the obsessive compulsive in the name, but it's actually completely different. It's not characterized by intrusive thoughts, images, or urges and repetitive behaviors. Instead, it is an enduring and pervasive maladaptive pattern of excessive perfectionism and rigid control. So, needing a lot of control in their life, a lot of like set patterns and stuff, without the need for any type of like really compulsive behaviors.
So the medications that are commonly used to treat OCD, the first recommended is SSRIs. So SSRIs, they regulate mood. These ones are commonly known Prozac, Sarafem, Luvox, Paxil, Celexa, and Lexapro. These are the most recommended ones for OCD because they are efficient, safe, and that they are tolerable. And then there's also SRIs, which are a little different because the SSRIs only affect the serotonin in the brain. The SRIs, they help with mood, and also they usually treat chronic pain as well. So these are the secondary choice of medication for OCD, but they also tend to have a lot more side effects than SSRIs. And then studies have shown that SSRIs are proven to be effective in reducing OCD-like symptoms within 8 to 12 weeks.
And then therapy for OCD. So cognitive behavioral therapy is kind of the umbrella that covers exposure response prevention therapy and acceptance and commitment therapy. So they're all kind of like derivatives of each other, but the exposure response therapy, or they call it EPR, is real life or imagined exposure to anxiety invoking stimuli without engaging in the compulsion after the obsession has been triggered. So this might look like if you have a contamination domain of symptoms, maybe handling an object with germs, like frequently turning on and off a light switch, so that you can kind of get through that obsession without necessarily, like cleaning the light switch or stopping yourself. And then OCD, that has primarily obsessions. Some research has shown that listening to the obsessions on repeat may help reduce the severity or intensity of them as they become more monotonous and you increase the exposure. And then the cognitive behavioral therapy is really looking at how to change the appraisal of the stimuli or appraisal of the obsession. So in OCD, you might deem the obsession as wrong or needing to get rid of it. But when you change your appraisal of the obsession as, oh, it's unimportant, it's nonsensical, and continue about the activities, that can kind of release this need to control the thoughts and even help with self-soothing. And then acceptance and commitment therapy is very similar to both CBT and even mindfulness therapies, which is focusing on seeing the thoughts as thoughts and learning how to be open and welcoming to unwanted inner experiences or acceptance of them, which ironically decreases the distress that they have about their distress and allows attention to shift to the present task at hand. So basically looking at like this is an OCD thought and I'm having the thought and it's distressing and I can't control it rather than I can't control the thought. So the thought is like I'm having a thought that I can't control it, however I can, versus like, oh, I can't control this thought. So learning how to kind of describe them as OCD thoughts and observe them without focusing on the content of the thought itself. And accepting that it's happening and that you can continue to go about your daily life. So that's the acceptance and commitment portion. And then community resources. So NAMI is a good community resource. It's the National Alliance for Mental Illness. And they have like a lot of different family support groups and groups for people who have different mental illnesses. However, it's based on the chapter per region. So the NAMI chapter in Kern County is unfortunately not as does not have as many groups as say LA County does, or even Orange County, where you can actually like join supportive groups. So there's not really supportive groups in Bakersfield, but the International OCD Foundation offers like the potential to join online groups and just different resources and articles to learn about the disorder. In terms of community treatment in Bakersfield, Kern Behavioral Health and Recovery Services is like one of the bigger community agencies that provides mental health treatment to those who have Medi-Cal or any insurance really. And they kind of can provide treatment like EPR, cognitive behavioral therapy for people with OCD. But overall, I think there needs to be kind of some more specific resources to OCD because it can be difficult to treat. And I think there could definitely be a benefit for having more clinicians specialized in this treatment in Kern County offering services that accept Medi-Cal versus just private practice. So that is the conclusion of our presentation. These are some of our references. And in the next video, you'll be able to see a case study in which we provide kind of what an assessment for OCD might look like.
Thank you.
Thank you.